So I'm here to talk about my favorite subject besides my kids, and that is diabetes reversal. First, my disclosures and the problem. I know in this audience here, people are well aware of this, but we are in the midst of a terrible epidemic. So the last time this was published in a major journal was in JAMA, looking at 2012 data. This was published in 2015. And over 50% of adults in this country have diabetes or prediabetes. I mean, it's really striking. And the consequence of this is we can't afford this anymore. Okay, of course, the primary consequence is people's quality of life, their length of life is being really impacted. But when we look at what is really going to drive change, unfortunately, we all know money talks. And take a look at what has happened just over 6 years. I mean, we cannot afford to allow this disease to continue to spiral out of control. And here is the bottom line. Type 2 diabetes is reversible. And, for everyone in this audience, this fact that type 2 diabetes is reversible is everyone's responsibility. So for those people who are healthcare providers, it is all of your responsibility to let your patients know this. For people who are not healthcare providers in the audience, it's your responsibility to let your friends, your coworker, your family members understand that they are not trapped in an irreversible condition. They have their own options on how to take care of their disease, and they can back out of where they start. All right. Okay, so there are actually 3 clinically proven ways to reverse diabetes. Bariatric surgery. The literature is quite robust. I mean, we do get reversal, and we get prolonged reversal in many cases. A very low-calorie diet has also been shown to reverse type 2 diabetes, and a low-carbohydrate diet. Now, I bet no one will be really surprised, especially at a conference that has low carbohydrate in its name, that I'm going to focus on the third one. But it's really important to understand that there's not just one option. And that is because patients have a choice. All right, so what does not have evidence of diabetes reversal? Sorry, this looks like it smudged together. And that is the standard of care. So a study at Kaiser Permanente, a really large study, looked at what happens, what is the amount of diabetes remission that occurs following the standard of care. And it doesn't, okay? So what doesn't work? We have 3 methods that work, one doesn't, yet we're constantly talking and practicing the one that has failed us. It doesn't make any sense. So, focusing now on low carbohydrate. So, just really quickly here, why does carbohydrate restriction work? Because we know it does, but what's the physiology behind it? And again, it's that different macronutrients produce different glucose and insulin responses. And when we remember, what is the problem with type 2 diabetes? The problem with type 2 diabetes is elevated blood sugars, right? But even before the blood sugars became elevated, the pre-problem, if you will, is elevated insulin levels. And it's just so important and really so simplistic to understand that our 3 food macronutrients create very different elevations in both glucose and insulin. Carbohydrates cause them both to go up. And it is really important for everyone to understand, not just the people in this room, that fat does not cause a glucose and insulin response. And so if we want to instruct our patients to eat something that actually will control the root cause of their disease and not just band-aid it as we do with more and more and more medications, we have to instruct them to eat what scientifically makes sense. And everyone is an individual, and personalization is key to sustainability. But although everyone has individual quirks in their own physiology, what we see here as far as their responses to macronutrient are just generalized to humans. To really mammals, carbohydrates will cause the glucose and insulin to go up, and fat is flat. So fat must be a part of science-based recommendations for anyone who has type 2 diabetes. So let's talk about healthy carbs, because our guidelines, again, that have failed us, are full of recommendations for healthy carbs, right? Well, it's okay. It's a healthy carb. You know, I'm not eating white rice. I'm eating a really healthy carb. It's brown rice, right? So a cup of brown rice with 45 grams of carbohydrates in it is going to cause two really different responses in individuals, depending on if they have a high or a low carbohydrate tolerance. Okay, and clearly when we're talking about type 2 diabetes, we're talking about the person in red, the person who has a very low carbohydrate tolerance. So ingesting these healthy carbohydrates are going to cause an excessive insulin response. And of course, we'll go back to why are patients with type 2 diabetes generally overweight and often morbidly obese? Because these high levels of insulin being our fat storage hormone, cause problems. And what do? What do we all do? We blame the patient, right? They're not following our instruction. But we gotta go back and look at this simple physiology. Wait, we really set this person up for failure. So again, this is from the American Diabetes Association guidelines. The total amount of carbohydrate eaten is the primary predictor of glucose or glycemic response. Okay, so let's take a look at one of my patients that I saw very recently. So I pulled this CGM data just this weekend. So his starting insulin dose was 210 units a day, which if anyone who is seeing patients with type 2 diabetes, that's what? Pretty typical. That's pretty typical. That is not like a patient who comes in once in a blue moon. That's, you know, the patient at 9 o'clock on Wednesday. And his starting A1C was 11.3. So this is 3 years into a low carbohydrate ketogenic diet. And this is his CGM reading. Insulin dose today, 0 units. He's still on 2,000 units of metformin. And his last A1C was 6.1. And I'm going to predict from this glucose curve, again, that I just pulled. Oh, actually, no, this is an old one. I'm sorry. This is from April. His last A1C was 6.1, which was about 4 months ago, so pretty soon after this glucose curve. But you can see what happens, right, when you remove the carbohydrates. So this guy had consistent ketones and a flat curve now. And I want to stay on this for just a minute because I really feel that the ability for us to give CGMs, the continuous glucose monitors, to our patients with type 2 diabetes is going to be a game changer. Because when they can actually look at this and see this happening and go, oh my goodness, I can't eat this, you know, they're going to wind up policing ourselves. And what we're going to get there is another facet of support for these people, which is really exciting because when I throw a CGM monitor on someone, I am just super excited to watch what's going to happen. Because I'll tell you, even in the patients who we've been working with for a long period of time, once they have access to that data in their hand, like the real time, and they can see the curves, not just these simple points, I mean, it makes all the difference in the world. Okay, so many of you may have heard this study that came out recently, right? And for people in this room, I bet a lot of you had the same response to it as me. Duh. Okay, so this was picked up by the media, though, and flashed everywhere. Oh my goodness, even people who are well, who don't have insulin resistance, are having these daytime surges when we put CGMs on them, right? So this is going to, again, really help push carbohydrate restriction further, because what we're going to be seeing, which we have not been talking about in the past, is this is a problem with everyone. So since I have a CGM and I wear it all the time, I decided to do a little experiment. This is me deciding to sit down and have watermelon with my kids in the morning. This is a healthy carb, right? Now, I have no diabetes. I have no insulin resistance. My triglyceride HDL ratio is well below 1. And my goal, the blue bar there, is set to 70 to 100, okay? This spike, it was 170. 170. And I get asked a lot, like, well, how much were you actually eating? I'm like, not much. Like, I sat down and had a bowl of watermelon with my kids. This is me. This is a problem. So this was just last week. I was so bothered by this that my new plan is I'm going to come home and I'm going to slap in a CGM on each of my kids for 10 days. And so my kids are just going to roll their eyes and go, oh my God, and my crazy mother again. But I'm like, I want to know what's happening, right? I mean, we have low-carb kids, but I don't restrict fruit. And now I'm like, man, do we need to restrict some fruit? I don't know, but this is really bothersome to me. Okay, so how about this? When we talk in the general public, away from this type of audience, one of the questions we always have is there's not enough evidence, right? That, we have to go with the guidelines because the guidelines are where all the evidence is. They're evidence-based. So if you want to come up with this new idea, you just have to have much evidence to support us changing our ways. And quite frankly, right now, it's not there. Anybody heard that before? Anybody had that argument? There's not enough evidence. Okay, so let's take a look at this. So looking at low carbohydrate intervention as a treatment for type 2 diabetes, there are 20 randomized controlled trials, 5 meta-analysis, and 10 other published trials, all supporting carbohydrate restriction for diabetes treatment. Now, we all know that as a general rule, low carbohydrate intervention is not recommended by the American Diabetes Association guidelines. I mean, the last iteration, they said, well, maybe for 3 months or so, right? Like maybe we could do it short term, but you can't do it for long term. So what do they recommend? The eating patterns that they recommend are the DASH diet, Mediterranean diet, and plant-based, right? So let's see how low carbohydrate compares to all the evidence of the recommended evidence-based eating patterns. There it is. So here, the light blue is randomized controlled trials plus meta-analysis. And then when we add in other clinical trials, here's how low carb stacks up. And I would love, take a picture of this, okay? And show it to anybody who tells you that there's no evidence, okay? I mean, and the thing is, I'm gonna be working on more and more graphs of this because, the other thing was, well, the studies weren't long enough. Actually, overall, taken together, the studies on low carbohydrate had more people and were longer, okay? And there's just more of them in general. So it's just not true. Okay, so now I want to go back to talking about evidence and spend some time talking about our ongoing study at Indiana University Health. So this was initially 2-year, and we have increased the time of this study to 5 years, non-randomized prospective controlled study. And I'm going to come back in a little while to talk a bit more about study design. But we recruited 465 patients, and in our active intervention arm, there are 378 of them, of which 262 had type 2 diabetes, and the remaining 116 have prediabetes. The usual care arm were patients recruited from the same community, all at IU Health, but they were being given nutrition instruction by the diabetes educators. You can see here that the mean BMI of our patients was quite high, so these were not cherry-picked patients. And the other really important thing about this trial at baseline is we were recruiting all comers, meaning we weren't putting restrictions on insulin or length of time with diabetes. In fact, if you see here, the mean years that people had type 2 diabetes was really long. These were really sick people. If you compare that mean years with type 2 diabetes to other studies, including other reversal studies, you see see that our length of years with diabetes is significantly longer. Once again, not cherry-picked people. So our primary outcome was body weight, metabolic syndrome criteria, and type 2 diabetes status. Secondary outcomes, we looked at a number of things, and we also still have bank samples that we're going to be doing a lot of fun stuff with. So what happened at a year? So A1C reduced, and it reduced significantly. So we went from a starting average A1C of 7.5 to 6.2 at a year. And a couple really important points on this graph, which is just how fast this improvement occurs. And the reason that that is so important is because it motivates patients, right? We have to remember at every single graph that any of us put up, there's all these patients that make up those graphs, and they are all important. And for each of those people as an individual, they want to see results that actually work, or that are actually meaningful quickly. They want to be given instruction that works, and they want to be able to see the improvement very quickly, including, one of the my favorite things to hear from a patient is when they start at the clinic and then a month later they say, "Oh my gosh, I can't believe it. The very next time I went to the pharmacy, my cost was reduced already." So this quick drop is important for each of those individual data points. But again, we don't see the drop and then a rebound, right? We see a continual decline out to a full year. And if we look at the gray bar above, this is the usual care. So remember what type 2 diabetes has been called by many organizations, including the American Diabetes Association. It is a chronic and progressive disease. And I agree with that statement if we're using standard of care. That's what happens over time. We slowly get worse. So again, it's not just the A1C that was improving. It was the medications that were also being reduced. So 57% of the prescriptions for diabetes were discontinued. And if we look here, like sulfonylureas, which, I think for any of you who work with these patients, like this is the first one to get people off of, right? I mean, it's taxing the pancreas. They're just, in my opinion, nightmares. But unfortunately, in general practices, we turn to them all too often, right? Because they're cheap. We were able to remove all sulfonylureas. And for insulin, 94% of the patients who began the trial on insulin had the insulin decreased or totally eliminated. And if you can see, the total elimination was really significant. But, this goes across to other classes of medications too. And the one you see not that much of a change in at the end there is metformin. And because metformin has indications outside of type 2 diabetes, and no matter how wonderful we make their glycemic control, these are people who had type 2 diabetes, and they are at risk. And so I really feel like metformin is one that I have a risk-benefit discussion with the patients about, and I let them choose. I say, we have reasons to believe that this may be helpful in the long run. And some patients are like, great, I can stay on it, it's not bothering me, it's super cheap. And other patients are absolutely, I want off of it. So I let the patients choose. And then you see that we did add some GLP-1 agonists. And the reason clinically that I do this is it's a great bridge to get people off of insulin, because we know those high levels of insulin are going to impede their weight loss. And we just want, and it also causes risk, right, of hypoglycemic events. We really want to get people off the insulin as quickly as possible. And that's kind of my favorite way to do it, is we switch them just to another injectable, and then we can get them off of those over time too. But really, we've reduced their hypoglycemic risk quickly. All right, so not only do patients get off of them, but of course, this doesn't surprise anybody, with that much reduction in medications, we're saving money as well. So medication reduction at a year was 46%. And again, remember, this is just medication reduction. This doesn't yet take into account all the other costs associated that make up the over $300 billion a year now, such as reduced productivity, days off of work, hospital costs, all those things. And do patients stay engaged, right? Because in addition to the argument that there's no evidence for it, the second biggest argument I get is people can't do it. And so 83% at a year. Like when we look at prescriptions that we write for our patients, there's no way at a year 83% of them are still taking those prescriptions. Okay, so this people adhered to better than a pill. Don't tell me that's not sustainable. Okay, so our goal was not weight loss. Straight up, we told patients that's not, if you do it, great, that's a wonderful benefit. But despite the fact that our focus was not on weight loss, people lost a lot of weight. And as you see, we do not have the 6-month uptick that you see in most weight loss trials, right? People lose weight for 3 to 6 months and then we go up again. But here we are all the way out to a year, and we aren't continuing to lose on average, but we're flattening out at a much lower weight. So in addition to publishing our 1-year diabetes-related results, we also published a 1-year cardiovascular risk paper as well. And this is my favorite graph, probably from the whole trial so far. And it looks at all these markers of cardiovascular risk, comparing our intervention to the control patients, which are in gray. And so we can see here, really, our intervention patients rocked it as far as cardiovascular risk goes. What is the one exception where it got a little bit worse? If you notice here, LDL-C did go up a little bit. It went up by about 10%, which many would consider very significant as far as increasing cardiovascular risk until you take a look at their ApoB and LDLP. And Ron already talked very nicely about this, in that in these patients, they can have a normal LDL-C or a slightly elevated LDL-C, yet their LDLP and ApoB can be sky high. But that's not what we were seeing here. We were seeing the increase only in the LDL-C. Their ApoB and their LDLP actually went down slightly. Wasn't statistically significant. But the point is, we weren't increasing this risk. So really, we had all these improvements. Yes, you can reverse your type 2 diabetes and improve all these other risk factors and not be making other things worse. So that's really exciting. And so how about their 10-year risk score? We took a look at that too. And again, what happened with our intervention patients compared to usual care? It's more of the same thing. And so liver function, another big problem and another big cost associated with type 2 diabetes is all the problems people get because of fatty liver disease. And so here we see a significant improvement in liver function as well. So kind of to take a look, big picture overall, really 60% of the patients in the intervention arm at a year reversed their type 2 diabetes, which means they had a glycemic control under the diabetes threshold and were off all diabetes-related medications with the possible exception of metformin for the reasons I discussed before. And, again, medication reduced while the improvement in A1C, weight loss, and improvement in cardiovascular risk factors. What's not to love from this, right? So here's a question. And I know I'm running short on time, but I want to make sure that I cover that. Did they actually eat what we told them to? Right? Because in any nutrition intervention, we're giving them instruction, that's all well and good, but the question is, did they do it? And how have we tracked this in all prior nutrition interventions, right? We rely on food records. And what do we all know about food records? They stink. They stink. They're not good. They're fraught with error. And it really makes, I believe this is actually one of the reasons that nutrition science is so contentious. Because no matter what someone publishes, someone could come up and say, oh, they didn't really do it. Your food record, method stunk. We can't say things definitively until now. So did they actually eat a ketogenic diet? They did. Because we had a biomarker to follow. We followed beta-hydroxybutyrate. So our study is really unusual. We didn't use food journals. Our patients didn't have to write down everything that they were eating. We used this as a marker, and yes, they were doing it. So I think not only is this in and of itself important for this particular study, it also brings us to a question of study design, because we did not do a randomized control trial. And, that's often a criticism. Oh my goodness, everything needs to be a randomized control trial. That's the gold standard. And it's the gold standard and makes really good sense for drug studies. But the problem with nutrition studies is that the people have to be invested in it, especially if you're planning on doing a long-term study. So if you all of a sudden take a group of people who, let's just say, have been following a low-carb, high-fat diet, and you tell them all, well, we're going to put you in a study, and half of you are going to have to be vegan for 5 years, or anything, that really significant change to their diet. And they're not invested in it. They don't believe in that. It's not going to work because you're not going to get the compliance. So you want people who are invested in it. And this goes back to my argument of patient choice, right? Patients need to choose the intervention that they want to follow. And I think that that's really important. So the idea of randomizing that is a little tricky. So how do you support sustainable behavior change? And support from many angles is critical. So the patients in our study actually had a ton of different ways of getting support. They tracked their biomarkers and were able to follow them. They all had a health coach, and they all had a physician following them. In the trial, it was me. And they were able to coach based on those biomarkers to help people and really make it personalized for them. They had a patient community, and they also had a ton of resources that they had access to. So the other thing you need to really have sustainable changes, and you have to give people advice that works. And, And again, we know from the graph how quickly not only this works and works for a long period of time, but people are excited to eat this kind of food too. The idea that people can't stick with it because it's boring and doesn't taste good is just not the case. So I just want to end with this, reminding everyone that there are 3 clinically proven ways to reverse type 2 diabetes. We need to be talking about this. We need to let patients know that they once again have control, because telling a patient who is diagnosed with type 2 diabetes that they are stuck, that it is progressive and reversible and there's nothing to do about it, takes the control away from that patient. And when you can tell them there's something you can do about it, you can reverse out of this, and here are the ways. And the most important thing is then to give patients the choice. And I clearly believe that most patients, when given the choice, are going to choose a carbohydrate-restricted plan. But if they choose one of the other ones, that's fine. It's not going to be ever a one-size-fits-all for each patient. We have to respect that always. But the problem is that patients are not given the choice right now, right? They're not given the choice because this is not being discussed. So I'll go back to what I said at the very beginning. It's everybody's responsibility in this room to make sure that all people with type 2 diabetes know that it does not have to be a chronic and progressive disease. Give them the power back. Give them the choice. Thank you.